Good evening, Dr. Huck. Good to see you.
Madam. Thank you very much. How are you, madam?
I thought you, we missed you in the last class. I think in the last class you were not there, so we missed
Yeah,
you.
my mother was sick. She has got one carotid angiogram.
Oh,
So I stay with her. That's why.
take
Now
care.
she's
Yeah. I hope she's fine now.
yeah. Now she's doing better. Now she's at home now.
That's good. Yeah. So, friends, we also have a sad news from Padma. She's around with us. She lost her mother last week.
Oh,
Yeah. If you remember, she had made a mention about her health.
Sad.
Yeah, very sad to hear that. But Padma, very brave of you to have, managed this in this manner and also attending the programs and your sessions. Very brave of you. Yeah. Very sorry to hear about your loss. So today's topic of discussion is patient handoff. And I think those who are into patient management, hospital management, they would really agree with me. This is one of the biggest challenge in any healthcare facility. Because when you ask them to communicate something about a patient in a particular manner, we normally don't see that happening. And as a result, sometimes the patient's safety gets compromised, sometimes the continuity of care gets disrupted. We have fatal consequences also of these kind of errors in communication. I still feel that we do not take patient handoff very seriously. Do you agree with me, or there's a change in the system? I would like to hear from some of you who are actually, overlooking patient handoff and personally experiencing the real life situation. If somebody could throw some light on this.
Ma'am, patient handoff, what has happened is over a period of time, like I'll not say, and I'm an old timer MBBS graduate, but when as an intern, which we used to see previously, like when a patient used to be handed over, say between two, suppose there's a cross reference or a patient is being handed over to some other specialty or something, proper records used to be maintained at that time.
Mm-hmm.
Not that it is not being done, but over a period of time, some of the clinicians and they have lost they don't see that it's a very important procedure and it needs to be documented also properly. Many times mishaps have taken place, and since I'm the head of the medical admin, so it becomes many times it becomes a problem at times of any inspection or any assessments when they check documentations regarding handoffs. It is incomplete. Even if it is completed, it is not as per the this thing. So it is, yes, it is a problem.
So documentary lacking is still, I think, maybe if you're talking from the assessment point of view, it may be one of the NCs that you might get from the assessor. But when it causes harm to the patient, when it actually disrupts patient's recovery or patient's treatment, that's very heartening. That's very sad. I think that's where we have to understand that we might consider handing over as just one odd responsibility. But how important it is that this patient was under my care for these 6 hours or 8 hours or 24 hours. And now the next person who is going to come and take over this patient should know what happened in this case in the last 24 hours and what that person is now supposed to be doing, or what care or responsibility or precaution this person has to, take. I think that is something we really need to, value. Personally, if you ask me, whenever I ask, different set of people, how do you hand over? Like, for example, when I ask nurses, so usually they'll say, ma'am, we go bed to bed for handing over. Maybe in some setups, actually proper handover happen. Padma, you are joining from another device also? Okay. Yeah. So they'll say, ma'am, we go back to bed. I don't say that no, they are not doing it. Maybe yes, in some places they go back to bed and they hand over the patient, in a very meticulous manner. But then when I ask them, in case if the other one comes late, usually the other person can be few minutes late. So then how do you hand over? Ma'am, if the person is very late, then we do it at the nurses station. We just take out the patient's case sheet and we just case by case we kind of hand over. I said, if the person has come further late, maybe say 15-20 minutes late, then what do you do? Do you still go back to bed or do you do it on the nurses station? No. Then we do it in the changing room. We change and then we keep telling the important things and we don't go case sheet by case sheet. And in case if the other person has come further late, usually the handover is at the gate. In just one line, everything is okay. What has to be done, I have written. In case if you have any question, call me and let you know. I think you'll agree with me. The reality is this. And when I ask doctors, how do you hand over? You will be knowing better because you're seeing them every day. A lot of time they say, ma'am, हम कहते हैं ये सब ठीक है, इन दो को देख लेना. That means don't worry about all this. These two are serious patients, just concentrate on them. So how vague and wide is this handing over? Patients who are waiting, for treatment or for some follow-up or for some referral, these things get delayed just because we forgot to tell, or the person who received information did not take it seriously, did not do the follow-up, did not take timely action. The whole process gets delayed by 24 hours. If you didn't send the sample, if you didn't collect the report, if you didn't keep the patient empty stomach, if you didn't put the patient for procedure, the patient stays for another couple of days, and that adds to the patient's cost and also a revenue loss to the hospital. I think you all must be experiencing this day in, day out. So can you think of anything that happened in recent past where the proper handover was not done? It could be in lab, because in lab also critical reporting has to be done. In case there is extreme deviation from the normal range, it has to be quickly, immediately informed to the concerned consultant. Maybe we need to repeat the test. Maybe we need to call the patient and ask to immediately go and see the doctor, or whatever the protocol is of individual hospital you need to follow. So I want to really understand, how are we doing this in lab? I think Ryan is not there, otherwise he could have told us about lab. Dr. Haq, you have any idea about the in the lab, how they are managing?
Sorry, in the labs, this handover process is actually very much important, especially for the critical lab test. Sometimes it's happened that's as because I used to work in for Epic Healthcare. It is close to Chittagong Medical College and hospitals. From there many urgent cases came for test. Sometimes it happened that the sample collections, they didn't make the proper handover, and because of that it was very difficult for us to manage the patient and patient attendance, especially the IMOs working at the ward to give the reports on time, and it was very difficult. So if there is no proper handover takeover, especially for the critical lab test, there could be severe problems in patient management and also for the reputation of the institute.
I'm sure many of you are assessors, like even I go for assessment a lot of time. And when we ask them about what protocol are you following for critical lab report, I mean, from their expressions, you can make out that there is actually no protocol. They're not following any protocol. There is no proper way of intimating to the patient or to the consultant or to the department that this case has to be either repeated, or we need to, redo the test, or at least, pay attention, whatever has to be done. So that's what I'm saying, that I think in number of areas, this kind of handover is considered very casual. It's not taken seriously. So any experience, Dr. Vabevi, you would like to share from your workplace about ineffective handover where you experienced patient harm?
Yes, in fact, in the past, maybe you can say 3 years back,
Mhm.
we used paper to document and give the handover to the next shift.
Yeah.
So it was like a document. The papers were put on a writing pad next to
Mm.
the patient, and then we would do. But over the last 3 years, we realized that there are a lot of communication documentation error, because when you read the document as a third person, so
Mm.
let's say somebody has written it, but when you read it,
Mm.
it actually lacks crucial information, which
Mm.
is it is important. Sometimes vital parameters are mentioned, but one subjective look of the patient कि मुझे ना ये patient ठीक नहीं लग रहा है, though the
Mm.
vital numbers look okay, but how
Yeah.
about documenting even that aspect of that, that I have seen and I feel this is not okay.
Yeah.
Subjectively. So we would actually miss out on those during handovers, and shifts change, and those subjective signs also disappear. So we started using the online one, which
Mm.
now there is paperless. We don't have any paper,
Mm.
and that has actually made it easier, because all the doctors who are involved in the care of that patient will have the access on their phones,
Mm.
where they can track. Then there is, if in case they deviate from the vital signs,
Mm.
they generally creates a flagging and alarm on
Mm.
independent. So the nurses, the doctors, whoever is involved is, they know. So when they come together to talk to each other, recently things have sorted out. But yes, in the past there was a challenge of missing information,
Yeah.
which was a problem.
See, although we put a lot of emphasis on documenting, but the problem is if you don't read the document, it's as
Yes,
good as not having the document.
I agree.
So I think you're
Absolutely.
right. If we have that system of reporting online, then at least anybody from anywhere can access that information and get
Yes.
updated about what is happening. So, Dr. Kapoor, your experience in the government setup, because I know that's a very, volatile, area. So, what is your experience with handing over?
Definitely, as for a private sector and government sector, are two different scenarios altogether.
True.
The number of patients which we cater to and which we are required to cater to is huge in number. Sometimes, definitely, we also wish we would be giving the same standard of care which private is able to give.
Yeah.
We are trying our best. I'm also looking after HIV/AIDS part.
Okay.
Director of AIDS control. The moment also I'm in charge of ART center in my hospital.
Okay.
Here I can say about that lab reports, viral load and CD4.
Mm.
There we have totally contact with each and every PLHIV which we are catering to. The
Mm.
moment we come to know that CD4 is falling or viral load is rising,
Mm.
we contact them personally on the telephone. And believe me, in the COVID times, we even delivered the medicines to the home.
Wow.
No private would have been done it. I can vouch upon that. So we had that setup of community participation that people will go to the houses of PLHIVs and deliver the medicines so that they don't lose out on their medicines, giving them at the home as well. But considering general OPDs, sometimes it becomes really very difficult to give that type of personalized care which we are really aiming at.
Yeah, I think we would have very handful of people who would actually go to the extent of delivering the medicine to the patient's place, because there should be no disruption in the medicines. I completely agree. There's a message by Dr. Haq. I want to read that for everyone. Now we do handover in WhatsApp and Messenger. I think that has really helped us because it's quick, it's easy. I completely agree with you. And the concerned person would follow up the case. I completely agree. Thanks to this new technology that's helping us in improving the communication. Yeah. So handover of the plan of treatment. Yeah. So that I completely agree. We are using technology, but we need to be more systematic in communication. So Dr. Ravi, in ophthalmology, what kind of handover do you do with your nurses or with your fellow ophthalmologist, if I may ask you?
Ma'am, now things have improved a lot because again of technology that we at every stage I take photographs and I keep of the clinical picture. So I would say more like when we are referring, so then date wise I will send these are the pictures, and I tell the patient even sometimes because I am living in a very small town,
Yeah.
there's no tertiary medical care,
Yeah.
and we often have to send it to a super specialist.
Mm.
So, and I always tell them, that, you tell the doctor he can phone me, whatever, sometimes because, sometimes you get all kinds of, the doctor will say, Isne kya kiya wo, but at least we can then tell them the patient came to me at this
Yeah.
is what I have done, and I'm very open about it.
Yeah.
This is one thing which has helped us, but, earlier it used to be I mean, so many times we have patients, because I'm a rather senior practitioner. So I get mostly patients who have been shopping around, to 10
Mhm.
people.
Yeah.
And
Yeah.
then sometimes you are at sea, what has been going on, partially treated. And,
Yeah.
it's a terrible situation.
Yeah. Yeah. And when you
So at
don't
least when we face it,
competence.
having faced poor handover ourselves, at
Yeah.
least we try that our colleagues should, and this is where little technology is helping, but it has not been so in the past.
So clear. Also, when you are sending a patient to a higher setup or tertiary care setup, there has to be a proper way of writing the referral letter where you actually
Yes.
are supposed to give, a brief about the patient. I mean, the person who is sitting on the other side may not get time to go through the complete case sheet. So can we have one page, summary of the
Yes.
patient's case so that the person can read and would know the immediate, important information about the patient, and look into the case and start working. So that's also part of handover. But how many of us really know the proper format of writing that referral letter? That's also still, very, very, very doubtful. Deepika, you wanted to say something. Please go ahead.
Yeah, so actually, ma'am, in Qatar, the major inpatient facilities are with the public sector.
Yeah.
So, you find a lot of polyclinics here. So here we do not actually have the practice of, documenting the handover and all that, because it's just a medical center OPD basis. But, recently we had an incident where in our lab, the staff had collected the sample, and we have majority 80% of patients coming in from insurance. So since they did not get approval, they did not process it. But since the handover was not done, and unfortunately the staff had to leave for some emergency. So the sample was lying in the lab for 3 days without being noticed. And once we got to know, only once a patient came in looking for the reports. So this was kind of very alarming to us, and now we are trying to establish a process to curb this situation. That's what I wanted to
See,
share.
this is what I was saying, that in labs, usually these kind of lapses happen. Even there where there's a 24 hours, patient care, like for example, nurses, if they don't have a handover properly, the patient, there can be lapses in the medication or in the care or some procedures or preparation for a procedure, all that can definitely, get compromised. Yeah, Dr. Janvi has raised a concern, a confidentiality issue. I completely agree with you, but I think as long as the information is being used by people who are directly involved in the patient care, I think then it's all right. If you are putting it across a WhatsApp group where people are there from different departments or different specialties and who have nothing to do with the patient, then of course I completely agree with you that then we have to really devise a mechanism where such lapses do not happen, and this is definitely very important. Yeah, Dr. Haq has written, we use dedicated mobile set and number for handover. Okay, yeah, so that means you are not using any personal number or personal mobile on that. I agree with you. Yeah, any other input from anybody, from Rehan, from Mr. Hashim, or Dr. Farha, anyone, if you have anything to say. Rehan, I hope you know what we are discussing because you joined a little late. So we are discussing about the handing over. So handing over, usually we consider it's something like that happens in indoor, where normally the patient is handed over by one set of staff to another, and usually amongst nurses, but that's incomplete. Actual handover can happen even, for example, when the patient is referred to another setup, or for example, in lab, if you have any report which needs to be attended immediately. For example, if the patient's numbers are very high or very low, and that requires immediate attention, or when the patient is being moved from one care area to another, like Dr. Vaibhavi has written, from ICU to ward, or from emergency to ICU, from ICU to OT. So these are all different patients being moved from one care area to another. They're all called part of handoff. And healthcare, handoff is considered Bermuda Triangle of healthcare. It's considered Bermuda Triangle of healthcare. One of the biggest reason is we are still not taking handing over as seriously as it should be taken. We assume, what is my responsibility? I have done. That's all. And then if I don't say, and if I don't write, and if I don't communicate, what about the next set of people? How are they going to manage? And that is something we are going to discuss at length today. So Dr. Ravi has written, this is such an important aspect of communication. Healthcare personnel. Oh yes, healthcare personnel, healthcare personnel. Absolutely. And this has to be taken seriously. So one of the common barriers that I think in adopting handoff, one is that we are still in that mindset of solo practice. If we are especially working in a smaller setup, and if we are specialists in our area, we think, I know about my patient, I know it all, I know how to manage, I'll remember everything, I don't have to tell anybody. But we are forgetting that healthcare has become very, very complex, involving a lot of specialists in one patient. So definitely each team member has to be informed and be updated about what is happening in the patient care. That is why I think this concept of online information is designed so that you have access to the information from anywhere, and you know what has happened. Then also, a lot of us think that it is only for nurses. With doctors, I think that's one of the biggest challenge. They think handing over is for nurses and not for us. Dr. Vaibhavi, do you agree with me on this? Completely. Because we think that why the hell should I hand over? Why the hell should I hand over? Or people think, I know what has to be done and I'm doing it. Why should I tell to anybody? Like Deepika said, the person who was supposed to be, doing those tests knew that these tests are not to be done till we get the approval. He or she did not inform the next staff, and that mishap happened. So I think that is where we really need to come out of, that mindset. So if you remember, we did one activity right in the beginning, in the first session, about that patient who actually had undergone, surgery for calcified tumor under third and fourth rib. Do you remember that case? I'll just share with you. I'll share with you the screen, and I think that is one case which has probably, really shaken me, that how sometimes we don't realize how important it is to, take every bit of information about the patient very, very seriously. I'm just putting that case once again for all of us as a reminder. Yeah. So I hope you remember this case. This patient was in the ICU, and he was operated for calcified tumor between the third and fourth rib by a cardiothoracic surgeon. So this patient, after a while started complaining of numbness below the nipple area. The surgeon was informed immediately, but surgeon was not there in the campus. So he telephonically said that please send a referral to the neurologist on urgent basis. Unfortunately, everybody informed, but nobody did it on the urgent basis. And what happened exactly was this, that the neurologist came to see this patient after 16 hours. Something that had to be intervened immediately was attended after 16 hours. And unfortunately, as a result, this patient suffered irreversible paraplegia. And of course, the hospital had to compensate for the loss. So how much ever money you pay, nothing can actually compensate for a loss of a life. And look at the age of that person who became paraplegic, 21 years old boy. And it's so sad. Another case, again, what I'm sharing with you are all real life cases that I've seen or I have heard from the audience. This patient was admitted in a hospital emergency with acute MI. He was managed well, settled, he was waiting to be moved to the CCU. In between, the patient desired to go to the toilet, and his wife went and asked the nurse, "Can I take my husband to the toilet?" This nurse had just come on duty. She had no idea about the case. She said, "Go ahead." Unfortunately, this patient was taken to the toilet and he collapsed in the toilet. We lost a life just because proper handover was not done and the staff did not know that this is a case of acute MI and this patient has to be immobile and stay in the bed. Another case, again, sharing with you, this lady was a wife to the hospital employee. Imagine, to the hospital employee. So this lady delivers a normal, healthy child. She's shifted to the ward. And in between, she has a feeling that I'm bleeding excessively. So she asks her mother-in-law to go and talk to the doctor or the nurse on duty. And it was around late evening, around 8 or 9 o'clock in the evening. So the person who was on duty was about to leave. They said, "Okay, let the next staff come and see you." They forgot to tell to the next staff. After an hour, the mother-in-law again went to the staff who had come on duty, saying that my daughter-in-law is saying that I'm bleeding little more, I think more than normal. So when these people went and saw, she had already gone into PPH. Unfortunately, this lady also was lost in that, loss of information. Another case, this patient was a case of preeclampsia. This was recently shared with me by a gynecologist. So she said that the patient came to the regular emergency, general emergency. Whoever was on duty, they said, give injection magnesium sulfate stat and ship the patient to the gynae emergency. They gave the medicine, they gave the injection immediately, and the patient was moved to the gynae emergency. But they forgot to sign and mention that injection given. They did not sign or they did not write that the injection has been given. So when the patient was taken to the gynae emergency, the resident over there did not see any signatures or any sign that this patient has received the injection, did not even ask, unfortunately, that this device is on. Can you please put on mute mode? Yeah. So the resident in the gynae emergency gave this medicine once again. Unfortunately, she received the second dose of or repeat dose of the same medicine, went into respiratory distress, moved to ICU. In the whole process, the lady was saved. She came out, but unfortunately, they lost the baby in that process. So you can see these cases that I'm sharing with you, they're all real life cases shared by people like you and me. And this thing is happening right under our nose. Unfortunately, only 3% of the errors get reported. 97% of the errors are brushed under the carpet and they are presented as complications. But we all know that there are lapses. Patient care hand of communication have been identified as one of the critical safety and quality problem, even by JCI. They did a study where 3,000 sentinel events were studied from 1995 to 2004. 65% of these cases were because of the poor communication, which actually became 70% in 2005, and 50% of them were during the handoff. Poor handoff was responsible for these lapses in the patient care. I think this tells us more than the what we are actually missing on. The problem is we do not take handing over seriously. And we'll talk about it at length to first of all understand. And then I think you will be using this information to train and sensitize your staff to the importance of effective communication. So,
Ma'am, sorry for the interruption.
Yes,
but what happens in such cases of gross negligence on the part of the hospitals?
So Rashmi ji, very honestly, with due respect to all the hospital administrators around us, I think all effort is made usually to hush up the case.
Oh,
mostly because the consequences. The thing is, even the person who does it is afraid that I will be targeted or I will be punished or I will have to repay either in the form of monetary loss or some punishment. So we will be discussing this at length in the last session, and that is disclosure of medical error.
Probably the patient's family may not be aware also as what has happened at the other end. As you rightly said, it's brushed under the carpet and
yeah. But in a lot of cases now patients and their family members are very alert. They are more suspicious than they are, they on the basis of assumption, sometimes they unknowingly they blame the hospital or the doctors for negligence where actual negligence hasn't happened. But then they blame that the case was not looked after well, and that's why the conflict is on the rise, and we all see the things worsening every day. And in the last session, I will share some studies with all of you where hospitals have gone, with the protocol that there will be 100% disclosure of medical error. Of course, not in India. These are foreign studies that I'll be sharing with you, and how they have been benefited by practicing this. I'll be talking about that at length in the last chapter. But right now, we are majorly focusing on the Handover protocol. Can we learn some ways where we can actually implement handoff in a real manner, in a practical manner? That's what we are trying to understand. So evidence studies suggest that there are when there are ineffective handovers, we have talked at length about it, you will see wrong treatment happening. You will also see there can be delay in the treatment. For example, if the first staff forgot to tell to the second staff that this medicine has to be started at this time, the next staff got to know only once the patient reminded or the resident reminded, then the treatment was started, so there can be delay in the treatment. Of course, severe adverse events we have seen. I've shared a lot of cases with you just now to let you know when there is ineffective handover, how that can compromise patient safety or continuity of care. Of course, patients are now very alert, rather super alert, and they're always suspicious of some malafide thing happening with them. So a lot of complaints and dissatisfaction you would get to notice amongst patients also. Definitely, there is increase in the healthcare cost, and this is a revenue loss for the hospital also. It's not just for the patient. It's not just the cost for the patient, but it's a revenue loss for the hospital also. And of course, there's increased length of stay when the care doesn't happen timely. The patient's discharge and recovery gets delayed and postponed. So definitely that increases the length of the stay. And there are a number of studies. I've written a couple of studies here, but there are many more studies that say the same thing in this. So in a study in 2016, they estimated, in US hospitals that medical practice, basically the communication failure I'm talking about, at least in part of 30% of all malpractice claims, it resulted in 1,744 deaths and a revenue loss of 1.7 billion. All because of communication failure between us. So we have talked about it, the lapses that you have experienced in your setup. And I'm sure there may be many more stories that you would like to share about how you have suffered personally, or your patient has suffered, or your hospital has suffered because of ineffective handing over. And as we said, what are the primary challenges that we are facing? One of the major reason of this problem is that it is still an unstructured and one-way communication. If you'll observe people handing over and taking over, the person who is handing over will do most of the talking. The person who is listening is probably still not mentally in that space. That person is in mood, give me the chart and go. So usually it becomes more like a one-way communication. And we all know there is extreme variability in a medical ward. a different kind of handoff is required. In ICU, in CCU, in CTVS, in other specialties, a very different kind of handoff is required. The patient is moving from ICU to ward, from ward to ICU, from ward to OT. A different kind of handoff is required. So there cannot be one line solution for all handoff. So that means you really require different set of protocols for each kind of handoff. And it is estimated that in a typical teaching hospital, around 4,000 handoffs takes place in a hospital. So imagine the number of time this activity is done, how frequently it is done. So that means we really have to find out a way that works for most of these situations. And then time, commitment, and process change. So if I may ask a question to all of you who are actually into hospital management and directly handling situations, in how many hospitals have you kept additional overlapping time between the two shifts where a proper handover can take place? Dr. Vaibhavi has raised her hand. Okay. Deepika also has raised her hand. Okay. Dr. Nair is also saying this. So if I may ask three of you to briefly share how you are practicing from your work area, that will help everyone to learn from three of you. So one by one, Dr. Vaibhavi, would you like to share very briefly? Yeah, very briefly.
You mean to say the handover aspect?
Yeah, how you're overlapping. So how you have been able to do that? Yeah.
So generally the shift begins at 8 in the morning, and the previous night shift has to wait till 9. So an hour of handing over happens, and that handover is largely done using a template which we follow, and we take it through all the patients. We also end up flagging, like you said, after every patient is handed over, which are the patients which require priority care is also discussed, and what is the plan for that. Once that shift gets over, I think the previous batch has to come 1 hour early, and that's where the formal handover happens. During the handover, there are challenges. Sometimes a patient may become sick because so there is a buffer which is kept of one shift in charge who looks after all the critical patients as and when the shift happens and the handover is smoothly going on. So there is always one person who is a buffer to make sure that during the handover, somebody is looking at the patients as well. Otherwise, that could get ignored, and for an hour, there's no monitoring.
But that happens across all three shifts?
Yes.
And across the hospital?
Yes.
Across the hospital?
Across the hospital.
But not only in critical care areas, even in the regular medical.
Even in the regular wards, yes.
Wonderful.
Because there is no way out. Otherwise,
wonderful.
Handover completely nahi hoga.
That's so good. And since when are you practicing this?
This is almost like I think since 5-6 years that I've joined this hospital, I've seen this, and they pretty much, yes. In fact, I'm talking about the nurses.
Yeah.
For doctors, it could be a challenge because if they have to hand over and they have to go to the OT, the handover could be on phone. The handover could be like, okay, just meet. These are the crucial points. So the time pressure is also very important. I think doctors do have challenges because this is where between two doctors is a highest challenge.
Yeah.
Especially if there's a hierarchical difference.
That's again an issue.
And then between a doctor and a nurse is a challenge, but between a nurse and a nurse is pretty robust.
Yeah, we will talk about this. We'll be talking, but I'm glad that you're already practicing this overlapping time, because that's one of the major reasons for not being able to implement handing over in a very systematic manner. Deepika, if you could briefly tell me what are you doing to make sure that there's overlapping time?
So here in Qatar, we don't have, But in my previous employer, whom we had got the NABH accreditation, so there we implemented this process of overlapping, especially as how Dr. Vaibhavi told, it was more with nurses, so nothing with doctors or anybody. So across the hospital, we implemented for a nurse's handover, and there we were more easily able to do because majority, like 80% of the nurses were staying in the accommodation provided by the hospital. So we made the transport system in such a way that the hospital nurses come in before half an hour and ensure that the handover overlap is there, so that the time was managed accordingly. So this was done in my previous employer, not here.
Great, thank you. So Dr. Nair, are you also practicing something like this, or it's something different?
Ma'am, and since ours is it's a medical college hospital, so what we have done is that we have put the duty rota in such a way that the relieving doctor comes, so that the timing is that the one's duty finishes at 6:30, the other's duty is starting at 7 o'clock. So half an hour gap we have kept for both. So then that half an hour the handing over is done, ma'am. As Vaibhavi ma'am had told, between doctors is the most difficult part. Nurses is sorted out, ma'am.
You can manage nurses. I know you can manage nurses. They would abide by.
Doctors we have made in such a way that the complete duty rotation is made. Half an hour we have kept it, ma'am.
I know. I completely agree with you, and I think that's the biggest challenge with most of the hospitals. Nurses, you are able to, make them do whatever you want to do, but the biggest challenge is. So, any other hospital, Dr. Janvi, Dr. Haq, Dr. Kapoor, in any hospital, if you are able to, manage doctors, if you have been able to effectively.
So, ma'am, as said, everyone said that nurses are easy, we have overlapping duties. Even for doctors, we do have overlapping duties, but yes, it is a challenge. We have a documented handover. How the nurses have, we only thing we have made it very, very concise as to what they need to actually give handover, not the entire history, but any significant events or something. And what do we follow? We follow the unit system basically. So, though there are 3 doctors around the 8 hours shift, but still there will be one senior RMO 24 hours for that unit. So even if, and he will be in the campus, so if they have to ask him or her whatever the questions or queries, he will be the one who will be coordinating the entire care for that unit. Though he's not on duty in the night, but he's the care coordinator and the one point of contact with the consultant. So that is what we have tried to do. Yes, but we have.
I think that's with most of the hospitals. They'll have somebody senior always on call who would actually show up. But the problem is the direct care has to be provided to residents, and in case if they don't coordinate, then there are lapses in the continuity of care, and that's why where the patient basically suffers. So I think the whole idea about when we are talking about the barriers, I think one of the barrier is that there is no overlapping time kept for handing over. Until you will have it in your system, you will never get that commitment, and you will not be able to actually implement this process. So I agree with nurses, it is easy. With doctors, it is difficult, but you will have to be really very creative in finding ways. How do you really make them do? And of course, not much research is being done to understand the impact of ineffective handoff. So if you will do studies, if you will try to find out in your system, in bits and pieces, you will get to see the impact of ineffective handover or the benefit of effective handover. So we really need to come forward and do these studies to see its actual effect. So some of the barriers that I've already discussed with you, as I said, still people have that mindset of solo practice. Some people say, I know it all, I will remember everything, I can manage everything on my own, nothing will happen, there's no need to tell everything to everybody. And some people also feel that I can't follow the rules. Some feel it's time consuming, and a lot of us say that it is for nurses and not for us. I think the biggest challenge is making this happen for doctors. For nurses, I don't think it's a challenge for most of us. So a study was done where 12 simulated patients were picked up, and they were actually handed over in 5 consecutive cycles, but 3 different styles were used. So in one, they handed over just the verbal handover. In the second one, they just handed over the patient with the written handover. But in the third one, they used a standardized form with verbal handover. And I mean, nothing to be surprised of. Actually, in the verbal handover, almost all information was lost. Whereas in the notes form, when it was given handed over in the notes form, almost 31% of the data was lost because there was no clarification, there were no questions, there was no verbal exchange of the information. But with the standardized format and verbal handover in combination, there was minimum loss. So I think this is one format we really need to follow and adopt in most of the places. Only documentation is also not helpful. See, especially when the patient is being transitioned from one care area to another. So, for example, when the patient is being moved from ICU to ward. Now, imagine a patient in ICU is under 24/7 care of doctors and nurses. And suddenly you are moving the patient to a private room. Now, this patient is in room but has no doctors, no nurses. Everything you have documented in the case sheet. Agreed. But do you think anybody in the private ward will sit and go through the complete case sheet of the patient? No. It's usually the last page or the first page wherever the orders are written. So orders are mostly about what needs to be done immediately. But it would not talk about probably the infections the patient is suffering, the allergies patient has had, or any episode of any mishappening. All that nobody is going to sit and read. Especially in transition of care, it's very important to not only document and hand over, but somebody should hand over the patient in a physical manner, should accompany the patient and hand over to the next caretaker. But the problem is this is not being done in a very systematic manner, and that is why we are losing, there's a disruption in the continuity of care. So the benefit of using standardized format, I think all of us are using. I don't know how many of you have really developed your own format. So have you developed your own format? Okay, Dr. Vaibhavi is nodding. Anybody else who has developed their own format?
It is more in the system. Like, let's say the online documentation has a format. So they have to fill, everything is made mandatory by IT. So उनको भरना ही है उसमें. तो उससे ज़्यादा हाँ, तो sometimes you have to go by default, you have to fill, even if it is the answer is no, they have to write no there.
Yeah. So even if I talk about the handover between nurses or handover from one care area to another, if there is a standardized format, even during the transition of care, if there is a standardized format, I think one of the benefit would be that it is not dependent on the person who is handing over, but it is focused on the patient, because it will have all the important information that the person has to fill in. Like Dr. Vaibhavi is saying, if there's a standardized format, I mean, there's no option. You will have to fill in that information. So automatically, the complete information will both the parties to have common expectation. What is going to be communicated, how it is going to be communicated, how the communication is going to be structured, and what are the required elements. So automatically, the information will be complete because nothing can be left incomplete. So automatically, the complete information will get handed over to the next care provider. Handoff is like painting a picture. The person who is handing over has to actually tell about what happened when I was here in the last 6 or 8 hours. So you are actually telling to the next person what happened in your presence. So it's something like painting a picture of what happened in the last 6 to 8 hours. Provide all relevant information. It could be about some drug allergy. It could be about the investigation or some sample sent. It could be about the referral sent. It could be about a procedure that is planned. All that has to be handed over from the person who is handing over to the other one. Of course, it should have specific directions with rationale. For example, if the patient has to be kept empty stomach, keeping empty stomach, for what reason? So you have to give the reason of whatever directions you are giving, and then also make sure that the receiver has understood. So on the other side, the receiver also has a responsibility. The receiver has to listen attentively. And we all know when two people are taking over and handing over, the person who is handing over is usually in hurry to go, finish it off. And the person who is taking over believes that I can manage, I will look after. So you will see very often they would be actually multitasking and not listening attentively. But the receiver has to listen attentively, ask questions to clarify. In case if you don't understand anything, if you ask, you will get to know why are you repeating this test? This was done yesterday. So there will be a reply coming from the person who is handing over. Or use systems to remember important information. I think a habit of noting down or having a small notebook where you note down your own key point is very important, so that you remember what needs to be done after the over is taken. And of course, read back or teach back so that you repeat and let the person know that he have understood it completely. So I think major thing that what we require in the whole thing is that there has to be a change in the attitude. We normally consider handoff as passing the buck, whereas it is not passing the buck, it is passing the torch. So it's something not like, dirty exchange of few facts, but it's a coordinated effort between two people, because both the giver and the receiver of the patient information has important responsibility. I would say something here: handover is never given. Handover is always taken, because the person who is going has done his or her job. It is now you who is taking over. So the responsibility is on you to make sure that the patient is safe and the patient gets to, get continued care. Even if you look at the definition of handoff, handoff is a transfer and acceptance of patient care responsibility. It is not just transfer, it is acceptance also, through effective communication. And it's a real-time process where the patient information is handed over to another person with the purpose of two things. One is continuity of care, and second is safety of the patient. If we remember these two things, I think we will never fail to give and take information in a responsible manner. We have to really learn the concept of handoff from some of the very high reliability organizations. So if you will look at nuclear power, NASA, mission control, aviation, even dispatch industry, courier industry, a lot of us are using Myntra and Amazon and Flipkart and so many, online. You will see very rarely a mistake would happen in the product or the delivery. That's how systematically they are functioning. So I would say, I would recommend here for each one of us to read that book written by Atul Gawande, and that book is called Checklist Manifesto. I don't know how many of you have read it. Has anybody read this book, Checklist Manifesto? Have you heard of Atul Gawande? Dr. Vaibhavi has read it. Wonderful. Dr. Matani. So Dr. Atul Gawande is a neurosurgeon in Harvard University. He's born to Indian, NRI parents who are also doctors. He is a wonderful writer. He has written beautiful books on the medical practice, and very honestly has admitted the kind of mistakes we all do in patient care. He doesn't blame anybody, but he says the systems are so complex that we cannot rely on human memory to function, in a effective manner. We really need to have systems. More systems you put in place, more error-free we will become. So this book by Atul Gawande, Checklist Manifesto, I would recommend everybody to read this book. And there's another book called Complications by him. Again, a very beautiful book, must read for everyone, because these books are, I'll share the screenshot of it. I'll share in the group. I think that will help you to, and if you'll go on Google, Amazon, you will find the link for it. Very beautiful book. Every healthcare professional must read it, because that's how you get to see, when you see people from healthcare writing about the importance of having systems in place. And we have to really learn. It's considered safer to work in a nuclear industry and to fly, then to get admitted into a hospital. 1 is to 33,000 errors. That means 33,000 errors happen in healthcare, and then you can hear 1 error happening in aviation industry. That's the amount of errors happening in healthcare, and most of it is because of our ineffective communication. So some of the common handoff you all must be aware of, like nurses shift change because they change their shift almost every 8 hours. Doctors also shift, there's a change in their shift, but we know that it doesn't happen in a systematic manner. Level of care, when the patient is moving from OT to ICU, from ICU to ward, or from any one specialty to another specialty. Sometimes it is also physician transferring care from their care area to another, or patient being transferred in and out of the hospital. So they are all common handoff. You must be all observing in your setup or across the healthcare. There are other types of handoffs also, which we normally do not consider as handoff. Like, for example, when you send a call for a doctor, or there's a critical reporting, that's also part kind of a handoff. Or when you send a referral note, or when you send a note for second opinion, and when you are sending the patient to other care areas like for radiology or physical therapy. So these are also type of hands-off, and we really need to know how do you really go about handing over. So this is one activity I normally do with the participants. How much time do we have? Okay, I think we will not do this activity, but we'll do some other activity that I want you to do. So this is a very common activity, and I would advise you to use this as a brainstorming activity with your staff, and wherever you want to actually sensitize them to the idea of effective handover. So what I do in this activity, I ask them individually to list down the things that you think an ideal handoff should have. So you will see each one of them will have 10 to 15 things written, okay, like patient's name or their diagnosis, demographical details, and present treatment or response to the patient, all that they will write down. Then you divide them into smaller groups and ask them to collectively come out with a common list. So you will see, for example, if you divide them into 4 and 5 groups, each group will come out with 10 items. You ask them to pick 10 items that you think that should be part and parcel of an ideal handoff for an indoor patient. So they will come out with some 10 items, and then from those groups come out with a final list. So when I do this activity, usually I get this kind of a response from the participants. So in a way, you're forming consensus, you're creating awareness, you're also getting their consent to the idea that at least this much we should be telling to the next person when we are having. So you are kind of engaging them to create their own handoff document by brainstorming and through group activity. So you can similarly do for your staff or your team members. This will help you to at least come up with one initial list of things that they think should be part and parcel of the handover. So the whole idea is that it should actually tell about the patient's condition, what care or treatment has been given, what medications the patient is receiving, what services have been provided, any recent or anticipated change to any of these changes. So when you briefly tell about all this, so in a way you have been able to provide all possible information about the patient. Let's do an activity around this case. Read this case and pay special attention to the line that I have underlined. And let me know, what do you think you're more likely to remember from this case? So in the first go, What are you likely to remember? Or what is going to strike you? You can write down in the chat box. Or if you wish to unmute.
Basically, it's not a critical one. It's like nothing to worry much about it.
Nothing to worry. That's one. Okay. True. What do others say?
That he is convincing the next doctor that the patient should be discharged somehow by weaning him off the oxygen.
Absolutely. So that means discharge is already planned. So this patient is likely to go. So usually when the patient is likely to go, that means nothing much to be done. So you will see very often when the patient's discharge is planned, actually people stop paying attention to that patient. In case during that time, if some mishap happens, nobody takes it seriously and they think, oh, the patient is fine and patient is going to be discharged. So this is exactly, when you hand over a patient like this, where you are saying that the patient is likely to go home tomorrow, so nothing much to be done. That means the patient is fully okay, and we just have to wean the patient so that the patient can go home tomorrow. So it's something like when you're talking to your dog, you say everything, but your dog would just be listening to the name because the dog is familiar with, your pet is familiar with the name that you have given it. So you may say, okay, Ginger, I had it, stay out of garbage, understand, but the Ginger is just listening to one word, and that is Ginger. And this is what happens when we hand over in this manner. That's the risk. That's the real life situation. That's the problem if you hand over like this. The problem is there's always, a cognitive process interfering with handoff, like selective attention, selective listening, selective forgetting. And do you remember the video that we had seen last time? Do you remember that video? Then I asked you to count the number of time the white ball was exchanged. Do you remember that or no? Selective attention. We had seen that video where gorilla passed through the activity, but none of us noticed it. You missed it, Dr. Matani. I think you were not there in that session. We did this in one of the activities. Yeah. So selective attention, selective listening, selective forgetting, these are common cognitive processes that actually interfere with the effective handover. And you may say you deliberately forgot. It's not deliberately. That's how the human cognition functions. Some of the other barriers, like Dr. Vabibi was mentioning, one of course is complex system. The handover in ICU, CCU, critical care area, it's going to be very different than in a medical or a surgical ward. Volume of information. It's impossible for anybody to remember or anybody to actually say verbally about any patient. Time constraints we have talked about. Unless you have an overlapping time, you will always see the staff who is to go will be in hurry to go. The one who has come will always come at the last minute. Then of course we all know there's a limitation of learning and training. Not all of us are uniformly trained or have not learned the right way of handing over and taking over. So we may not value handing over and taking over as a very effective way. There's a continuity gap when the patient is not handed over to the right person. So definitely there can be a continuity gap. Human fallibility like fatigue, burnout, attention, all that can interfere with the effective communication. Negative impact of fatigue, we all know there are chances of forgetting, there are chances of selective attention and selective listening. Then confidentiality. Of course, a lot of time we don't share the information fearing, oh, this will compromise patient's information. But actually that would be required. For example, if the patient is attempted suicide and has shared with you, and you don't share this with the next staff, thinking that the patient will say that I shared this with you with confidence that you will keep it to yourself, but why did you share with your next staff? you forgot, you did not deliberately share, considering patient's confidentiality, and unfortunately, the patient attempted suicide or did some self-harm. So that can also be a barrier. Then, of course, there are differences in styles of communication. Some people speak differently. Some people are passive communicators. Some are, very aggressive communicators. So all that can also interfere. Language can be a challenge. Maybe the language one person speaks may not be well understood by the other one. The person may not actually get the complete information. Cultural background, how you have been conditioned in your culture to hand over or to take over or to speak to people around you can be a barrier. Hierarchy of decision making, like Dr. Vabi was mentioning about this, a lot of time seniors do not prefer getting information from the juniors, or a lot of time it is assumed the junior is responsible for informing me everything and decision has to be made by me. So there can be conflict of responsibility. Then of course the level of empowerment, how much have you empowered your nurses, your residents, your staff. The level of respect between doctors and nurses also can interfere with the confidence that would, the nurses would have to report to the doctors, or come up to them and tell them about whatever information they want to share. Specifically, communication challenges between doctors and nurses, where we know the nurses are supposed to be reporting to the doctors. I remember I was taking a session for a group of nurses. So one of them said that a patient was being, operated for hysterectomy, I think. She said, after the surgery, I was counting the instruments and one of the artery clamp was missing. She was a very young, just joined. She had just joined, a very young nurse. So she said, I counted 2-3 times, but the artery clamp was missing, and I with a lot of hesitation, she informed her gynecologist, who was very senior, that ma'am, one of the artery clamp is missing. The gynecologist was very confident, very outspoken, in very rude manner. She said, are you sure? Have you counted? Did you count before keeping the instruments, or you have made a mistake in counting? She said, no ma'am. Again, she was very scared, but with little hesitation, she said, ma'am, no ma'am, I counted and I have the list written on my paper that these are the number of instruments I had kept. So she said, now what do you want? Again, in a little aggressive manner, she said, what do you want now? She said, ma'am, siyam manga ke, please get the x-ray done in case it. So they got this siyam, because now she had mentioned that this is the protocol and we need to follow. So they got this siyam, and incidentally, the instrument had fallen in between the table and the side of the table, fortunately. But then they could at least identify the instrument and it was like safe for the patient. But how many of us really allow that kind of communication coming from our staff? So a lot of it depends on, how we all know about the hierarchy. We know the level of respect we hold for each other, level of empowerment that we practice in our place of work, style of communication. Again, if you are aggressive, your residents, your nurses will never have the courage to come up to you and give you the real information. They'll be scared to put it across to you. And that itself can lead to, a patient care compromise. Your tone of voice, your style of communication, aggressive approach, language can be a barrier. So all this actually adds to, and also past experience. For example, if last time, if you were rude with your nurse or with your resident, next time your resident or nurse may hesitate sharing that information with you. And we all know that this is very common challenge in a lot of hospitals. Very senior doctors at times we see being very aggressive with the nurses and their residents. Now coming to tools of handoff. So how many tools? 1 second, there are a lot of answers in the chat box. I would like to read them. Give me a second. Okay, nothing much to do. Yes. Dr. Janvi says nothing much to do. Dr. Ravi says nothing much to do. Yes. So that means we are on the same. How can a patient on oxygen be sent home next day? So he is being weaned, Dr. Kapoor. The patient was being weaned and they were hoping that if he can wean off today, so we can send the patient tomorrow. So yes, he has to go home tomorrow. Is stable. So that's the understanding. then forced discharge to get bed vacant. Dr. Kapoor, yes, that can also be one of the reasons. I don't know. That could also be one of the reasons. And we have all seen this happening in the COVID situation. So, if I may ask you, what different tools of handoff are you familiar with or you are using already in your setup? You may write in the chat box or unmute. SBAR. Okay, Dr. Janvi has written. So, Dr. Janvi, is this being used across the hospital?
Yeah,
It's
nursing and doctors.
it's being used. Okay. And it's documented or
Documented both,
Actually,
like nurses.
is it on paper or it is on
No, paper. It is all written.
it's on paper. So a lot of papers must be,
Yeah,
generated.
so every patient every day, 3 shifts. So on a single paper, we have divided into 3 shifts and they write it down. So it's good on a single paper because then the night shift nurse also comes to know what was handed over between morning and the evening shift. So one paper, but yeah, all 3 shifts. Similarly with the doctor.
So the nurse before handing over actually completes and keeps it ready and then hands
Yeah.
over the paper in hand. That's
They
a good-
read it out and then the one who takes has to sign down, the one who gives have to sign down.
And are they able to find enough time to do that in a systematic manner?
So that's why we have, I can show you next session, ma'am, the sheet which we have designed. We have made a lot of tick boxes and, so a little easier version of over the time. Certain things they need to write down, but certain things they have to just like tick. So we are still in the process of
If
improvising.
you share a copy of it in the group so that everybody can have a
Yeah,
look.
I will.
They create their own template.
Yeah, next session I will definitely.
Yeah, just in the group whenever you are in.
Yeah, or in the group. Yeah, I will.
It's good if everybody has a copy of it.
Yeah.
Because it's nothing confidential. We want everybody to be benefited.
Yes.
Yeah. So Dr. Babri is saying ISBAR and I pass the better. So out of the two, which one do you find useful, Dr. Babri? ISBAR or I pass the better?
SBAR is much more simpler to quickly give telephonic conversation, in-person, critical event communication. I pass the baton is practically not possible because we have a system which already has that format.
Exactly.
But I actually give them like it's your mental model, You just make sure that you have covered every points, just in case you don't have that screen in front of you. What will you do? So it's like the backup plan, but in their mind it runs through that sequence.
So at least if you remember the format, then you would know what you are going to say after each item. That's true. I pass the button is little longer one, and it's practically if the patient size is large. For example, in a government setup where we have 40, 50 or 60 patients, practically I pass the button. Even ISBAR can be very challenging. So maybe you will have to really devise a simpler template for bigger hospitals where they actually can give at least the most essential information, then follow that. Yeah. So how about others? Are you familiar with ISBAR, SBAR? Dr. Ravi Matani, are you familiar with this? No, I was expecting because naturally it's you're in eye care, so this is something new to you. How about Dr. Farha? Are you familiar with ISBAR? No, not. Dr. Haq is also not familiar. Rehan, you would also like to know what is ISBAR and Dr. Nair, what any particular tool you are using in your setup?
Ma'am, in our setup, we have no bars because whatever bars we had, it was all a big failure. So we devised our own unique way of doing it, ma'am, and we have our own written format, totally tailor-made to our organization because ours is a typical organization, ma'am. So we have to have this thing. We don't follow any other formats. Because pass the baton, we failed the baton, so we thought, let's go for our own way of handing over of patients. So we have our own document, ma'am. I'll try to share that, ma'am.
Sure. Excellent. I think even I recommend the same. I would say learn from these tools, but devise your own template. There's no need to copy any template. If it doesn't suit you, it doesn't serve the purpose. Similarly, the Western healthcare delivery system does not fit as it is in our healthcare delivery system. So we can't implement what we learn from them. We have to modify it and customize too.
Because, ma'am, even the handing of forms, ma'am, to formalize it, it was a big Herculean task for us. But then we somehow manage that. Yeah.
I agree. I completely agree, and I understand what you are saying. Dr. Webby says rats. I haven't heard of this. What is rats, Dr. Webby?
Actually, for pain management, whenever patients have acute pain, there is a specific handover that we encourage all the nurses, is that they just call and say patient has pain. Arey, but aage kya? There are a lot of things that they need to communicate. So here we encourage them to say, okay, recognize the pain. So R stands for to recognize. That means where is the pain? So just point it out, ask the patient and inform accordingly. And also hand over कि उसको यहाँ पे specifically this pain is here. A is to assess the pain. That means the severity of the pain. We use different tools such as visual analog scale or numeric rating scales. So have you measured that? What is the number? T is treatment. What treatment has been given till now? So that means sometimes treatment means only medications, but no, there are non-pharmacological treatment such as pillow diya hai, ice fermentation, warm fermentation. Sometimes even for pediatric patients, breastfeeding calms them. So what have they tried and what has worked or what orders are written? And S is after giving this medicine, also after an hour, have you reassessed the patient? So basically giving a pain handover in a structured way actually makes the consultant understand, okay, this has been done till now. What has to be done next? Like that.
So it's actually properly, reporting the pain, not just saying that it's pain.
Yeah.
Yeah, that's good. Yeah. So I'm going to share one or two tools with everyone to understand. I mean, there are a lot of tools available, and it's always a good idea to use at least something that works for your setup. So, for example, I'm sure these are something that you must be familiar with. One is 5Ps, and I'll explain them briefly to all of you. Then the other one is SBAR. I'm sure you must have heard of. ISBAR is another one. Sign out is another one, and I pass the baton. So these are different tools being used across the healthcare facilities as a handing over tool. So for example, 5P is patient's name, the plan that you wish to do, purpose of that plan, the problem that you're anticipating, and the precaution that you are suggesting. So for example, that patient Ram, 54 years, to be kept empty stomach for barium meal test. The problem is he's diabetic. So precaution you want the staff to take is to check his blood sugar every hourly to avoid hypoglycemia. So this works for simple situations, but in a lot of situations, this does not work. For example, if you try to use this 5P plan, patient, plan, purpose, problems, precautions, and use in this case, try if you want to. Should I write the 5Ps in the chat box? Do you want me to write or you remember? Somebody would like to try? Anybody? So patient is Kishore, 14 years male. The plan is to wean him off oxygen. The purpose is he's going to be discharged tomorrow. The problem is in case his oxygen need increases, because you are not sure whether the patient will really be able to do well without oxygen. So the precaution one has to take is to check his SpO2 regularly. So, but even this is incomplete because there are many important issues that needs to be handed over to the next staff. For example, how about medication? How about hypoxia? How about infection? How about nutrition of the patient? Mental health, behavioral issues. So all that also has to be handed over to the next staff. So 5P appears simple and easy, but it does not completely share complete information about the patient. Also, we have not talked about any contingency plan for this patient. So in case if the oxygen need increases, what needs to be done? Or if the patient becomes febrile, so what needs to be done? So all that has to be part of the contingency plan. So 5P is not a complete tool to hand over a patient in such situation. So next is SBAR. So we, as I said, these are very commonly used tools, and each tool has its own benefit and its own flip side. For example, a patient admitted for cataract surgery. Patient is both diabetic and hypertensive. So you are talking about this patient to your staff or to your junior. So in SBAR, S is situation where you give the patient's detail. B is background. So background will include something like patient is diabetic and hypertensive. A is your assessment. So that will include patient's assessment, including clinical impression, concerns, vital signs, and early warning scores. And R is what do you recommend in that case? So what do you want, or what do you, or you're asking for what actions need to be taken. Most commonly used tool is SBAR, like Dr. Abhi is saying, and Dr. Janvi also says SBAR is being used in their setup. So SBAR is an acronym that says, okay, I stands for introduction, S is situation, B is background, A is assessment, and R is recommendation. So we'll understand this little more in detail. So when we say I, that means introduction of yourself and about whom you are talking. And then we check the identity of the person you are. For example, you're calling to another person. So first of all, you need to tell who you are. I am a doctor, I'm Dr. So-and-so, I'm nurse so-and-so, I'm manager so-and-so. I'm calling from ward 2. This is about patient name, bed number so-and-so, and room number so-and-so. And then am I speaking to Dr. So-and-so? So that means you really need to first of all identify yourself, tell about whom you are talking, and then ask, am I speaking to Dr. So-and-so? So this will give you clarity clarity to the other person who is calling, about whom, and then you are also sure that you are speaking to the right person and not talking to anybody who has received the call. So I is about introduction. Now S is about situation. That means what is the reason why you're calling? So what is the present problem that you want to be resolved? So it could be change in the vitals, it could be change in the mental status, it could be change in the patient's sensorium, it could be any preoperative observation. So examples are, for example, it could be I'm calling because I've noticed a change in the patient's sensorium. Patient is not responding to the verbal call or anything. Or it could be, I have received the lab reports of the patient's LFT and they are very high. So you want to immediately inform the doctor and seek their, opinion, what needs to be done. Or it could be, I started the blood transfusion and the patient is complaining of chills and rigor. What needs to be done? So again, what is the present problem becomes the situation, reason for you to call that person. So in such a situation, it's also helpful to give background of the patient, because the person on the other side needs to know more about the patient to take a call. So for example, if you are able to give details about the pertinent medical history like diabetes, hypertension, allergies, sensory impairment, family location, their religion, culture, country, or if you require interpreter or any valuable disposition that will help you, that will help the other person to take a call, that can become part of the background. So for example, when you say this is a patient who was admitted with overdose of sleeping pills, so the other person will immediately recollect, okay, we are talking about this patient. Or when you say this is the patient who is admitted with a large liver, so the person will know, okay, we are talking about this patient. Or this is the patient who's put up for surgery. The idea about giving background information is to help the patient know little more about the patient so that they can take a call even while being there. A stands for assessment. Assessment is what is your assessment, the person who is calling. So it could be about the vitals, it could be sensorium, it could be severity of pain, it could be bleeding condition, or anything that is your concern right now and what is your assessment about it. For example, if you think the patient appears very confused. So that means you are concerned about it and you want that to be attended immediately. Or patient's BP is very low. So that becomes your assessment and you want that to be addressed. And patient seems to be in severe pain. So like Dr. Webby had talked about rats. So here you can also say on a scale of 10, the severity of pain appears to be 7 or 6. So that would let the other person know what is your assessment while being closer to the patient. And R is the recommendation or the request that you want to put across. So recommendation could be that you are saying that I would ask you to come immediately, or tell me what can I do by the time you can reach. So basically this is one is that you want to tell the other person how urgent is the situation and what you recommend to that person to leave everything and come, or just verbally tell what can be done or send somebody. So that means from your end, you are either giving a recommendation or a request. So specific care required immediately or soon. Can you please come and see the patient immediately? Tell me what can I do by the time you reach here. For example, if it is because of the blood transfusion, should I discontinue the blood transfusion till you come and see? So these are the different options you are giving to the other person. So SBAR is a very often used tool basically when you are calling somebody for any intervention from distance. So you are supposed to give the information in a comprehensive manner and let that person take a call of what they can do. Any questions about this? About this tool? Because this is most often used.
So sometimes the nurses kind of hesitate to, use the recommendation part. That
Yeah.
means they say, "What should I do?" Okay, or "What should I do till you come here?" So here we also include the review part. So apart from recommendation, we tell them, you tell what has been done till now. So it's like a review of what you did, so that the consultant then can give you a feedback on the recommendation.
Yeah.
So otherwise they end up just saying, "What should I do?" That's the only sentence that they use. Because SBAR can be used as a question, or it could also be used to give an information. So when it is used to give an information, the R becomes a review of
Yeah.
what was done till now.
Okay. So review, recommendation, and request.
Request, yes.
So R can also be read as review. Very good. Yeah, true. So Dr. Matani says that S and A appears similar. Yes and no both. S is more like broad situation. For example, the patient appears confused. And in assessment, through assessment, what is your understanding of the situation? So I have checked blood sugar and the sugar is low or high. I've checked BP. The BP is low or high. Or the pulse is very feeble. So these are assessments of by examining or by doing some assessment, what is your assessment? That's what is the difference between situation and assessment. So I can see another this thing. Okay. So and any more questions or input on this? So very quickly, I'll share the second tool just to give you an idea about that tool, although we are not going to discuss that at length, because I Pass the Baton is a very good tool, but at the same time, it's very lengthy, and I haven't seen many organizations using it, but this is again discussed a lot in the different health handoff tools. So I Pass the Baton is again an acronym. I stands for introduction, that means introduce yourself. P is introduction of the patient and giving the demographical details if you want to give. A is about the assessment, the actual problem that you are facing or you want to be attended. S is the situation, that is current status and circumstances. It could be, recent changes also. S, which was missing in the other one, is the safety concern. For example, if there are any safety concerns, if you want to talk about, that will become second S. Now, or any threat or pitfall or alert that you want to inform about. The pattern is background and comorbidities. Again, with the same SBAR B would be this. It could be about the comorbidities or previous episodes or current medication or family, concerns. A is action. What are the actions to be taken, or what you have taken, or what action do you recommend to the other person? And brief rationale why you want to do them. Timing is level of emergency, which is not explicitly mentioned in ISBAR, but they have in this very clearly said level of urgency and explicit timing or prioritization of action. And then ownership. Who is responsible? So whom do you think is responsible for taking the action? It could also include patient and the family. So again, ownership brings clarity on what is expected from the other person, or who is the person responsible. And N is what happens next, anticipated changes and contingencies. So this is again a longer version of SBAR and more details on it. But I think the idea is that we should have some template, some format that helps us to pass the information in a structured manner. So telephonically, if we call, sir, us patient ka BP niche come hai, please come and see. That becomes a very incomplete kind of an information. But if you follow a tool or a template, it helps to give information in a structured manner. So these are some more, reporting tools. For example, SOAP is a tool which is used for recording a patient's, it could be even if you have been called for opinion, or the patient has been sent to you, or or if you are writing a patient's case study. So SOAP is S is subjective data, O is objective data, A is assessment, and P is plan for the management. Again, it's a kind of a structure, simple structure to help you write patient's detail. MIVT is more to do with the injury. So for example, M is mechanism of injury. Then injuries noted, where all you have found the injuries. V is vitals, and then the treatment. Of course, new one Dr. Vaibhavi has added is RATS. I will add that in the next session, and we'll have that there. If you look at the tools that we are talking about, I think the whole idea is to see how standardized tools actually are beneficial. And we all understand that if we are asked to speak, we all have our own way of telling about information. But if we follow a standardized tool, we'll make sure that patient's vital information does not get lost in that incomplete information. So the whole idea is the continuity of care should be looked after, patient safety should be ensured. Automatically it will lead to decreased error in patient care, decreased repetition also, like that case that I shared with you about magnesium sulfate, where the patient got second repeat dose of magnesium sulfate. That could have been avoided if the record was maintained and it was handed over properly. Of course, all this will lead to a better patient satisfaction. I'm sure you're already implementing this, but in case if you are still not implementing in a structured way, some of the implementation suggestions that I would like to quickly give you here is, first of all, assess all points where handoff occur. So go through your system, see where all handoff occur, then concurrently monitor processes at that point. So you will get to see how that is happening. Once you will see how that handoff is happening, I'm sure you will be able to identify the gaps. You'll be able to see how these lapses are ending up into communication failure and lapses in care. Then identify people in your system who would work as your champions. They could be a physician, your nurses, leaders, because everybody will immediately not get ready to the idea of bringing a change in the handing over protocol. But if you identify few people who are really enthusiastic and who are open to learning and experimenting with new things, take them initially on board so that they lead your idea of implementing and bringing a handoff in a formal way. Brainstorm with them to find the most suitable tool. There are tools available, but you can develop your own tool. The activity that I've shared with you, same activity you can do with your team depending upon your setup, and you can ask them to develop some parameters that they think would work sufficient to develop the tool. So once you have developed the tool, now select a consistent approach to handoff. So that means now you are going to going to implement it. So when you implement, you'll have to develop a policy and procedure, how you are going to do it, who's going to do it, how much time it is going to take, whether it will be on paper, whether it will be on computer, whatever policy and procedure you plan. Then you'll have to educate the staff who will be implementing it with you, for you. Implement the policy, monitor, and report the findings. Some things may work, some things may not work. Keep updating the tool, keep refining the tool, and then you will have a tool which is suitable to your setup. So, I mean, I think handoff should be implemented whether your setup is small or big. It should be implemented, and it will greatly help you in giving quality care to your patient and also avoid lapses in the patient care. So last two slides, the take home points that I want you to take with you. Please remember that 80% of the errors are because of the ineffective handing over. So we have to make sure that this becomes part and parcel of the patient care to ensure continuity of care and patient safety. Only written handover is not enough. In a lot of hospitals, I see they're maintaining documents, but actual handing over is not happening. It has to be supplemented with the verbal handover. Handover is not given, handover is always taken. So, however effective handover is, it is the responsibility of both the parties. So, once who are giving handoff, they need to be very specific, concise, and deliver the information in standardized format. And make sure to ask to repeat the information to the receiver so that they can confirm whether the person has really understood. The person who is receiving the information has to listen attentively and summarize in between and ask questions in case if the information is too much to take. And don't forget to read back to make sure that you have understood everything before you sign up. So I tried hurrying up, but still I think we have spent almost like 10 minutes extra than planned. Any questions about it? So even in place like labs, you can have a system of handing over. You can experiment, because I know usually we think it's with the patient care that we need to hand over. Wherever you're handing patient information, there has to be a proper handing over of information, whether directly in the patient care or indirectly. It has to be. So I'll be sharing the feedback for the session, not for the presentations. So I'll be sharing the feedback form in the group. I would request Dr. Nair and Dr. Kapoor, are you ready with your presentation?
Yes, ma'am. I am.
Okay. So Dr. Nair, you can now share your presentation, and floor is yours now. Go ahead, please.
Just give me a second.
Sure.
Ma'am,
Ji.
I'm not able to share my screen, ma'am.
I have enabled you. Multiple participants can share simultaneously.
I'm just having a screen on my view folder. It's written Zoom. That's it.
But have you touched share screen?
No, ma'am, not it. Ma'am, it's not there in my screen, ma'am.
Either it will be at the bottom of the screen. See, Doctor, who is sharing now? Somebody shared?
This one.
Yeah. Yes, you're already sharing now.
Okay, good evening, ladies and gentlemen. I am Dr. Nair. I am the head medical admin of Gujarat Adani Institute of Medical Sciences, and I'll be trying to discuss about the mostly used and mostly abused pedagogy, or which is used by everyone, that is a PowerPoint presentation. So in the next 10 to 11 minutes, I'll try to discuss certain salient points which can make us or help us making our presentations slightly more presentable. As Lily Walters had correctly pointed out, success of your presentation mainly depends upon what your listener receives. It's not dependent upon the content of your presentation, but what the listener understands. And before you plan your presentation, the three cardinal points which one should always remember is that you should be knowing the purpose of the presentation you're intending to make. You should be aware of the audience you're going to interact with, the number of people there, their intellect level should also be known to you. And finally, the importance of time. You should be aware of the time you have to speak for a particular subject. A same subject you can speak for 10 hours, you have to finish it off in say 40 minutes. So all these three cardinal points you should always remember before you make or start making your presentation. Now, the most important or most widely used way of making a presentation is to copy a presentation and just alter some fonts or some sentences and make it your own presentation. But ideally, the best way is to start with a slide master, which helps you to make your own backgrounds. In a simple presentation, limit the number of words you use in while making a presentation. Use only key phrases and include only essential information only. Try your level best to avoid all capital letters while writing a sentences, because many a times it becomes uncomfortable for the reader to understand what's written over there. Now, this is an example, ma'am, of a slide which was shared with us in one of our management lectures, and we got lost in the slide because the complete paragraph of one full page was pasted onto a view folder, and we could not get the head and tail out of it. So you should avoid making slides like this. Now, transitions. Now, be very careful while you are making transitions. While making a transition, I put in a noise also, or a sound. Many times these sounds may be distracting. So it may seem impressive, but be very cautious. Use it just to justify more of your presentation contents, like our ma'am does while she is presenting her, taking the lecture. Now, overuse of special effects may make your presentation cutesy, but may have a negative effect. So we should be very cautiously use animations and text flying ins and sounds during our presentation. A good quality photograph in your presentation makes a lot of difference in the way you communicate or you intend to communicate the thought. Like rightly told, a picture can speak 1,000 words. So try your level best to put in high quality photographs in your presentations. The rule of thumb is 1 slide per minute. But in this present scenario, since the time is limited, I'm cutting it down to 30 to 40 seconds. But the thumb rule is one minute per slide. So depending upon the total length of the time period you have to finish off the presentation, you can limit the number of slides. Then you should practice it, how to move it forward and backwards. Many times we can cut a sorry figure in front of the audience by flipping around. Practice it with someone. Like if someone is making a presentation for the first time from a big audience, it is always wise to practice it at least twice or thrice in front of your own people and take an honest feedback from them. Do not read from the slides. It becomes, many a times it becomes a monotonous. Many a times you might have realized that most of the presenters, they stand on the view folder and just keep on reading what's written on the slide. So because if you do that, then you lose touch with the people who are attending your lectures or come to discuss certain aspects with you. Then moving on to the fonts which to be used in a presentation, ideally people, wherever I have found out, most of the presentators use font Arial. Times New Roman is on another font, but many takers speak that if complex words, when they are written in Times New Roman, many people may not be able to read it. I personally am not in favor of that, but as like in many institutions, they formalize, like in our institute, we follow Arial and it is standard. Any presentation of our institute would be made in Arial. Ideally, in any presentation, the font size is also very important. So try to make your the font size more than 24 point. So that is very comfortable for the eyes also to understand what's written on the view folder. You should use the same font on the headlines, and you should use bold and different sizes of those fonts and headings or captions which are important. Headings should be between 36 to 44 points of a different color, or if it can be of the same color as that of the name of the main body of the presentation. Now, please remember, if you want to show something very important, or you want to emphasize on certain aspect, you can slightly make it larger. Avoid using long sentences, avoid abbreviations. For example, I'll just give you two examples, CDR and BDE. Can anybody tell me what do you mean by CDR or BDE? Very few people understand. Only army persons like me can understand. CDR is for commander and BDE is brigade. So if an audience has got a multitude or a big facet of people are there, then you should avoid using abbreviations and acronyms. And another thumb rule is not more than 6 lines and each line having 6 to 8 words. Now, this one slide format. If you observe this slide, I've used a dark background with a dark text, dark background with a light text. So always remember the color combinations. If you're using a dark background, always you use light text and vice versa. Like the color background which I'm using is of that of my organization. So it depends upon you. Again, I'll repeat, no all caps except for titles, very, very important. Repeating elements like page numbers should be put in one single location. Like I have put it in my right bottom corner. So we should always have a standard format for that. 6 deadly sins about PowerPoint presentations would be slide transitions. Be very careful about the sound effects you are putting in. If sound effects should be avoided, like if you're discussing very important topics, many a times sound effects may belittle your presentation. People use standard clip arts, like the one which I have used on my view folder. If you see disastrous, it's a standard clip art. Doesn't make much of a difference. So try to avoid using it. Presentation templates, please make your own template while making your presentations. Please make use of a slide master. Avoid using text-heavy slides. Again, I have put an example on the right side. Reading through the slides is another big dampener. One should not, you should be, reading part is left for the people who are reading the slides, but you should be interacting more. And faith in technology, which is the most important part. If you're going out anywhere to take a lecture or to conduct a class, please remember, please take at least 2 systems along with you, one laptop and in a pen drive. You should be having 2 separately, so that if one thing fails, the other one will work. To conclude, to have a successful presentation, you should make it as your presentation in a simple way. You should be grabbing the attention of people by putting it something unexpected, like a movie clip or a role play example. Your substance of the presentation should be absolutely have a concrete material for it, and you should be able to substantiate that. It should be made from credible material. Emotional sides or emotional things which are there in the presentation will help people and appreciate your idea. And please put in stories to emphasize your point, whatever you want to convey to the group. Thank you very much. Unfortunately, I had just 10 minutes time. Ma'am had given me strict instructions, so I had to finish it off. Otherwise, a massive topic. I've tried my level best to just put in all small details which one should be careful. Thank you very much.
Thank you so much. You have done a wonderful job in 10 minutes. Very nice. I think you covered almost all points of making a good presentation. And for all of us, it's a good learning. I mean, once you go through the video once again, you will be able to actually learn a lot more from the presentation.
Ma'am, I'll be putting this PPT in the group also, ma'am.
Wonderful. Thank you so much.
Because I learned PPT in the hard way, because before teaching in college, when I never used to take lectures. Once I was thrown into teaching line. So learned the hard way.
Yeah. Thank you. So if you could stop sharing, we could be
Yes, ma'am.
together in the main area. Yeah. See, the whole idea of making you do your presentation in 10 minutes is that at times you will get only 10 minutes. And we have to really learn to put our message in that elevator pitch style, where we can give the best in that much of time. And that is why I insist on following the time limit.
Ma'am, I think I have followed the time.
Yes, of course you have.
I had to rush through, ma'am.
No. Okay. I think you covered everything. It was fine. Beyond this, you would have just repeated what was written. It's better if you just stuck to the point and you covered almost everything. See, everybody is appreciating. So that means it's a good job done. Yeah.
Thanks, ma'am. Thank you.
Thank you so much. Thank you. I appreciate. So, Dr. Kapoor, are you ready with your presentation?
Sure, ma'am.
Please go ahead.
Is it visible?
I mean, you have to share the screen. You have not yet started sharing the screen.
I've shared the screen, ma'am.
No, we are able to see everyone. So that means we are still all in the main hall. Yes, now we are able to.
See my presentation?
Yes. Yeah, it has begun. Yeah, thank you.
So friends, very good evening. I'm here to talk about the role play as a pedagogy. And I've shared one story also in the morning about flow story. And story is another way of really involving the pupil and changing their behavior and making a change in the community. I hope all of you will be seeing that movie also, which is about child sexual abuse, to make a change. I've been working in these fields for years. I've been a public health professional, though I'm a pediatrician. I've worked as a director of school health, director of AIDS control. I've worked with sex workers. I've worked as a director of family welfare. And to carry those energies to you, I always believe whenever I'm making a presentation, I should transmit my energies to people who are listening to me. So today I'm talking about role plays, and as we have done many role plays since beginning of this training also, we have seen that role plays are the key part which plays in bringing the changes in the behavior, changes in the knowledge, and changes in the emotions part. Ultimately, what matters to me is not the knowledge, it's basically the change which I can bring with my presentation in the behavior of the pupil, in the emotional part of the pupil, so that they can really get attached and get connected with the pupil. So role play is a very important part. I usually do it a lot when I do my trainings part of it. And believe me, though we are doing it at the moment in a digital manner, when you do it one-to-one basis in a physical manner, the scenario is totally different. People get so much motivated. I've seen people crying when I tell them, to just enact a way when you were child sexual abused and how were you feeling about this. And I've seen people going into a crying mode, literally crying when they're enacting. They've not gone into it, they're just enacting it and they start crying. Similarly, people who are HIV, they were made to say, you have become HIV positive. And they were sitting in front of me numb. They were not speaking in a single word that this is my situation at the moment. I don't want to speak a single word. And now you please go ahead with your role plays. How are you going about? So it's a very important educational method which really bring out the human relationship in forward. Is ultimately, it's not the knowledge, is a human. We are dealing with the humans as a doctors. The human relationship has to be catered to. And that's what the role plays ultimately depict and portray to us. And ultimately, it's just not the involvement of one person when you are making a PPT. In role plays, people who are enacting it, they are involved. People who are observing it, they are involved. And everybody is really emotionally involved into this, what is happening in front of them. So very important mode of transmission. And I always say it's just not knowledge. It's affective, it's cognitive, it is behavioral issues, which all cater to when you are really doing a role play part of it. Purposes, we all know, we can talk about it, multifactorial issues which we are facing. No single disease is a disease in itself. I always call a disease is a multifactorial. If you go into the things, you will find they have relationship with the family, they have relationship with the society. So it's always an ecological model which we follow when we're talking about this. And this all ecological model is brought forward when you're doing a role play. You can't say, look, I'm suffering from asthma. And you go into details, you will find there's something in the family who is smoking. Something is, there is stress in the family. And when you really do a role play, you come out with all these issues, the psychological issues, situational analysis, many other things which keep cropping up when you're doing this role play and really getting involved into this. So it's the emotional issues also which are getting involved. There are 3 phases to it. When you're going to do a role play, please plan for it, implement it, and evaluation is a very important part. It's just not I've done a role play and I go ahead. No, first of all, the person who is sitting in front, if I'm a doctor, the patient is sitting in front, he has to evaluate me, how I've performed. And then I call the observers also, how have you felt about it? Are you feeling happy about it or not feeling happy about it? Did I miss anything or not miss it? So we have to plan everything, really selecting a problem, what is a problem. We have to be very concise. In fact, what happens is sometimes we take multi problem. If we are concise, we're talking about one problem at a then we can really bring out the other issues which are there, ecological model. If we take multiple issues, we may miss out some of the things. Set up a role play scene and start getting with the role play comprehensively. And usually we make them go out to explain, like Madam has done it. We have all gone into private mode when the role plays were being designed and people were given the scenario. Then they were given time to really think about it. Same way, we make people go out of the room to think about the issues, and then they specify their own names. They don't talk about their own names, they talk about some other name which they really like into this, so that identity is not there. Because this is very important, I'm telling you, to not disclose your identity also some of the time. Because sometimes when you're talking of yourself, you bring out your personal issues. This is very important. Whenever you're doing role plays, you take out your personal issues away. You really get into the mold of the patient, of the person, or the problem you are involved into this. So all these things are very important, and natural reactions then come out. As I've told you already, people may start crying, and let them do about this. And observer really has to be very, very sensitive about these issues. I've seen people start smiling when people is crying. So observers are also made to do that. Please be sensitive to the situation. The person who is enacting may have the emotional issues attached with it, or maybe bringing out his emotional attached with it. If you start smiling, the things will be spoiled. So observers also have to be very careful about this. And similarly, we have to talk about the implementation part, or we go about it, and then we ask for the feedback. We need to do a bit of briefing also. What is the script in the beginning? That's again done in isolation, taking the team out, and then we cast the roles. This is your role, this is your role. Again, people are allowed to choose their role. Sometimes if you force them, they may not give them the best. Let them choose their roles. What will they like to do become? You would like to become a doctor, you would like to become a counselor, or you would like to become a trainer. So that's volunteering part is very important. So their inner self, they're able to bring it out. If you force them, they may not be able to give them the best part of this. And that's what which we're talking about. Audience participation is very important, and you may have to stop the role play. Sometimes I have to do this once I see that now the things are diversifying into many other things. My focus was on this issue, which is already covered up. I really stop that role play over there. That's done. Let's discuss it further. And I ask the observer, what is the situation? So I will end it over there, that this is a very important type of pedagogy, which can be used, and different situations can be created for each learning part of it, so that we can bring out the most importantly affective part as well as the behavioral part of the part. The knowledge part is definitely being discussed in presentation. This is the knowledge part. But here we bring out the skill part, the behavioral issues. How are we managing different scenarios in the family? That's very important part of it. Thank you very much. Evaluation is very important. I will end it over here. Thanks a lot.
Thank you, Dr. Kapoor. Thank you so much. So could you please stop sharing so that we all could? Yes, thank you so much. Definitely, I think role plays are very, very, useful pedagogy. One of the useful pedagogies, because you can engage everybody in the role play, and it's being used more and more now across all training programs. And of course, there's some amount of projection and introspection and reflection when you do role play. Any questions around it, around role play? How many of you are using role plays as a way of teaching and training in your organizations? Dr. Vaibhavi, you are doing it. I know. How about others? Okay, Dr.
We also
Farah.
use it, ma'am.
Yeah, you are doing it. Yeah, I think it's a very good way of teaching and training. And also, when you just do presentation or you lecture, the audience does not get engaged. Whereas in role play, you can actually engage them, and then there's a lot of inner conversation, inner learning, which they do, when they reflect on the role play later on. And I agree, a lot of times the audience will become very overwhelmed, and they may start crying and become upset. No doubt about it. Yeah, Doctor. Sorry, Dr. Vaibhavi, please go ahead.
Yeah. In fact, in the simulation center,
Yeah.
we have banned presentations. So nobody brings a pen drive and connects. We tell them you have to interactively talk to them. So sometimes the trainers come and ask what to do if there's no presentation. So then we guide them, to make it more interactive.
Yeah. So just to share with you what Dr. Vaibhavi is saying, I did the train the trainer program with Dale Carnegie. I did 3 days intense program from morning 9 to 6. Rather, it used to start at 8 o'clock. My trainer did not use even a single slide, not even a single slide. But he could engage us through various activities and role plays 3 days. And we were around 40, 45 of us as, participants, and all trainers from different specialties. So that's the beauty of, engaging your audience. And presentation, actually, unless you have to give some information that needs to be given in that format. And even when you're giving presentation, it should have a mix of a lot of things to not make it very monotonous, to not let it be very monotonous.
I guess sometimes giving the information prior to the sessions is also a good idea, so that it takes out the need to present. So we give them beforehand, they read and come.
Dr.
Then they come for the session.
Dr. Vaibhavi, I gave that handbook to everyone. I sent a copy. How many,
exactly.
honest, how many of you even opened and read it? Raise your hand.
Honestly.
Just few hands. Actually, we all think, okay, we are going to attend a session, so we'll learn from that and then we will read. But if you have read, I'm really glad. That means my effort has not gone.
Ma'am, I've taken out a printout and it kept in my office library also.
Thank you so much. But you must buy that book also, that Fundamentals of Clinical Communication. Have you bought? And you must give me feedback also, what I need to change in my next, revised edition. So thank you so much. If there are no more questions, and it was really a fruitful discussion. I really learned a lot from all of you. I hope you also had a good learning in this session. We are left with 2 more sessions. We'll complete them in next week, because I don't want to postpone it to by another week. So let's meet on next Tuesday and also on 28th, that is Thursday. So next Tuesday and Thursday we are meeting again. Although it's very hectic for me also, but I just want to, end it in a manner that we don't feel that it has dragged beyond a point. So I hope everybody is okay with this plan. Tuesdays 18th and 20th.
Yes, ma'am.
Right. Thank you so much. So should I close it? Bye-bye. Good night.
Thank you.
Good night.
Good night.
Good night, ma'am.
Thank you.
Good night.
Good night. Do share your feedback. Don't forget to give your feedback. Thank you.